All right, just before our lunch break, I'd like to introduce our next speaker, Dr. Travis Brown. He's a general pathologist. He enjoys working in the fields of biochemistry, microbiology, anatomical pathology, and haematology. And of course, Travis and I work together on the podcast, This Pathological Life. And I must say, Travis does enjoy the diversity that general pathology provides, being able to work across multiple disciplines within pathology, and this really comes through in the podcast and the topics that we cover, which he blends with his unique method of storytelling. His presentation today, thank you Travis, is Serum, electrophoresis, how to interpret the results. And he discusses how to diagnose and monitor a variety of diseases or disorders that have abnormal proteins or protein levels. Travis, over to you.
All right, thank you very much for having me. My name's Travis Brown. So yes, I'm a general pathologist. So I'm probably going to change tune a little bit. I like to make things incredibly simple so I understand it. Hopefully that will help you out. What I'm aiming to do is an area that straddles chemistry and haematology. It's serum electrophoresis. And the reason, so the main thing with this is that haematologists manage this area often a lot in conjunction with general practitioners, but it's tested by the chemistry department, and so it sort of bridges that divide. So that's why I get often asked about, what do I do? So at the end of this, I just want you to know what serum electrophoresis is, when we do immunofixation, and what to do with it when you get that abnormal band. That's all. That's what we're aiming for. Okay, so let's see. Just going through. Again, very simple. What do we do when we get it? I didn't even come across serum electrophoresis when I was doing medical school, and it wasn't until pathology that I came across it. As an introduction, it's related to B cells, so plasma cells that produce protein. So I'll explain that a little bit more, but that's what we're aiming to do. So usually I'll get the phone call from someone saying, "Hi, I've got an abnormal band, what do I do with it?" And end of this, you'll know what to do with it. But we're always on the phone. We're actually on Twitter, on LinkedIn. If anyone has a question, just reach out, give us a call, and we'll go through with it then as well. So this is something only scientists will really see. Nothing for you to worry about, but it will just explain what we do. So we measure proteins. That's what serum electrophoresis is. So the biggest protein in blood is albumin. So that's the biggest band there down the bottom that you'll see on the left-hand side. You get that on every chemistry test that you get. You'll do albumin. We do it better than looking at this big band. But on chemistry, this is albumin. If you add up that whole amount on your chemistry test, that's total protein. So all of that added up gives you a gram. If you take away the albumin, that's what we call globulin. So you have total protein on your chemistry that's just a normal MBI that you order. You then have albumin, so you minus the albumin away from the total protein, and you get globulin. Now, if you can see there's a few bands there that are just a bit different. You've got an alpha 1, alpha 2, you have a beta band, and then the gamma band. The gamma one is the one where all the immunoglobulins are. So that's what we're worried about when we're doing serum electrophoresis. That's IgA, IgM, IgG, E and D. So that's the band that we worry about when we're actually examining serum electrophoresis. The other ones we tend to ignore. They tend to be, the alpha 1 is where you get alpha 1 antitrypsin. The alpha 2 is where you get the alpha 2 macroglobulin. And if you're starting to look at beta, you'll look at beta lipoprotein. Again, that's just academic interest, but this is just the full spectrum of proteins that's in the blood. So we literally get the serum, put it on a gel, put electrodes one side the other, and it just spreads out according to the speed or the size, and we know where they are. So when we look at that, that's what we're looking at when you ask for serum electrophoresis. If you look at the bands there, you can see they're spread out, so let's tilt it around. There's a band, let's look at number 7 down the bottom. You'll see a band that's just down the bottom, the most inferior part. That's actually a bit abnormal. That's in the gamma region, And you sit there, and so the scientists would have said, that's unusual, that shouldn't be there. If you look at number 24, top, again, in the same region, in the gamma region, there's an abnormal band. So the doctor has requested a serum electrophoresis. They've seen there's, however many there. They'll put it into the wells, they'll run it on the gel, and there's an abnormal band in 2 of those. We will then say, so you don't need to ask it, some people say serum electrophoresis and immunofixation. We reflex immunofixation. So what is immunofixation? Immunofixation is where we actually treat it with anti-serum, and that anti-serum just gives us tags on the protein. And then you've got, as you can see, GAM and kappa and lambda KL. And this just separates it out. So then we know that on the, let's say the top right, it's a G band. It's an IgG, and there's also a lambda. So you can see 2 bands in those regions. We now know that that's an IgG lambda abnormal band. So if I go back one, this is just out of interest. These are the immunoglobulins we're trying to measure. Now, the only thing I'll take note from is you've got IgG, so that's the one, 75% of all of our proteins in serum is IgG. That's what gives us our immunity. When we're vaccinating people, that's the IgG that we want to go up. Remember, it goes IgM, so I always remember that as IgM immediate. So that's the one that has the immediate response, and then you get seroconversion going into IgG, and that gives you the long-lasting immunity effect. So IgG is a small protein. IgM is very large, and that will become relevant in a little bit. IgA tends to be the mucosal surface immunity that we get, so, in gastrointestinal. And IgD and IgE is more the parasite area, but they're in very low, and they're pretty rare in these circumstances. So immunofixation. There's lots of things that can cause the gamma globulins to go on. Remember, we don't usually, if someone's got an infection going up, all the gamma region's going to go up. If there's autoimmune disease, again, it's autoimmune, so they're going to be producing antibodies, again, that will go up. So there are regions that these will go up that's not, let's say, monoclonal. The other thing to note is when we call it monoclonal, it's called an M protein, which is a bit confusing because you think, is that IgM related? No, it's just an M protein, monoclonal protein. So that's a little bit confusing, so don't get too worried about that. But yes, we have IgG, we have IgM, and we have an M protein, so it can get a little bit of a confusing. But these are the causes that goes up. The main one that we're worried about is multiple myeloma. So we're looking at, rheumatoid, Waldenström's I'll talk about in a little bit. But for the most part, there was an article that said in the US, the average hematologist sees 2 new cases of multiple myeloma per year. And they see 1 of amyloid and Waldenström's a decade. So it's pretty rare to find Waldenström's, and it's pretty rare to find amyloidosis. You'll probably find multiple myeloma. That being said, MGUS is the one that you'll come across the most. Okay, and that's monoclonal gammopathy of uncertain significance. So, going back to why we do serum electrophoresis, it's an excellent measure of tumour burden. It's a protein, the B cell is monoclonal, so it tells us there's very, very few cases, so 99% of people who have multiple myeloma will have a raised immunoglobulin. So it's a very good marker of that. If someone's receiving treatment, it's a very good marker of them responding to treatment. So they're the perfect uses for it. These are the associated diseases. So just very quickly, if we look, for the most part, multiple myeloma, 55% of cases is IgG related. We do separate it out a little bit, lambda and kappa, and the reason why that goes, if it is there, is that lambda tends to have a little bit of a worse prognosis. They have less free disease-free time period, and it tends to behave a little bit worse. That's just as a rule of thumb. We have a bit of IgA as multiple myeloma, and 1% is non-secretory. So, of a condition that's not common, 1% non-secretory, they will have other symptoms. So, but that's a pretty rare case. So for people with myeloma, 99% will have a raised immunoglobulin, 80% will have anemia. So this is the acronym CRAB, if anyone can remember that. So that's the people that have myeloma use CRAB as the acronym. So that's hypercalcemia. They'll have hypercalcemia, renal impairment, anemia, or bony lesions. I always put plus infection. So 70% of these people will have bony pain, 25% have recurrent infections and renal impairment. So that's, anytime I'm thinking in MGUS region, I always have that acronym there just to help me. Do these people have symptoms? The challenge with that is that a lot of the patients tend to be older, so they might already have some anemia that's not related, but you have to sort of figure that one out. And renal impairment, they might have a little bit, but again, that's a clinical distinction. It's a challenge for everyone. So smoldering myeloma, so multiple myeloma hits the diagnostic criteria of greater than 10% plasma cells in your bone marrow, usually has greater than 30 grams per litre in serum electrophoresis. Smoldering myeloma fits that diagnostic criteria, but they don't have any symptoms. So now they progress. 75% of them progress to myeloma within about 15 years. So if they've got it, chances are they'll get it in the long term, but it's just noting that they will probably progress. The solitary or the plasmacytoma, so we tend to classify them into two regions. One's intraosseous, so within the bone, and one's extraosseous, so outside, and that tends to happen in the nasal cavities and lung region. About 1/3 of these patients will have a raised M protein, so a lot won't. The ones in the bone will tend to progress to myeloma. It will take them about 10 or 20 years though, and it's a bit unpredictable as to how that goes. Those who have an extraosseous, so a lung plasmacytoma, local excision tends to be curative. So that's a good prognostic sign. Waldenström's is a hard diagnostic criteria because it looks, why it's called lymphoplasmacytic, it's down the microscope, it looks like a plasma cell, but it doesn't stain as a plasma cell. And these produce IgM, which is that very big protein. So if they're producing these huge proteins in that, these guys are at very big risk of hyperviscosity syndrome. So they're producing these huge proteins in their blood system, which then gets the blood thicker, which, if you use ESR, goes ESR. But again, the hyperviscosity syndromes, 50% of these patients will have that, whereas only 2 to 4% of people with IgG and IgA will have hyperviscosity syndrome with that. So it just tells you, heavy chain disease, it's there, but it's incredibly rare in amyloid as well. I'll just spread out MGUS a little bit, and this is because you'll actually come across this. It's uncommon less than 50 years of age, but 3% of the population over the age of 50 will have it, and 5% of people over the age of 70 will have it. So you actually come across it. The trick is if the globulin on the chemistry is elevated and the patient's not got infection or an autoimmune disease, it'll just say, it'll just be a flag, is something going on there? It is a clonal plasma cell disorder. The challenge with this is, I'll explain, is that yes, it's pre-malignant, but it's 1% of progression towards the disease. So it's keeping an eye on things. And as we get the aging population, it's probably just going to get a little bit more percentage. But there are no recommendations. There's no guidelines. There's a few recommendations about, which I'll explain. And I will give you a rule of thumb that we use at the end of the best way to manage it. There are high-risk categories. So if someone, as I say, if the IgG or IgM or IgA is a good measure of protein that's going up or tumour burden, if that's going up, then that's a risk that the patient, yes, is more higher risk than someone who's got a stable one. There is an Icelandic population study going on that started in 2016. It's a 10-year prospective study. And what these guys are going to do is saying, does it do anything? If we know that someone has a protein and we intervene early, is that going to be useful? So it hasn't, that we don't have good evidence that it does, and the treatment is reasonable once they've got the disease, but there's no preventative treatment. So finding out that someone has it doesn't change anything at the moment, so we're hoping to find out if it does. Not that you need to know this, but it's just useful for interest. There are 3 types of MGUS that are broken down. Again, IgM, non-IgM, and light chain. And this is because the disease associated takes you down a different path. Again, it's even talking to hematologists, they say, look, it's MGUS, so we just monitor it to go down. But it will just give you an idea as to the path that MGUS is going down, so you know the disease associated. And to be honest, for me, that helps out because then I know which path it's going down. So IgM, again, the really large protein. So if these plasma cells or lymphoplasmacytic cells are producing this very heavy protein, these guys, if you pick them up, have the risk. Now, it's 1% per year, so it's not often, but it's 1%. They'll have at risk of Waldenström's. Again, it's quite a rare disease, but the definition of MGUS is they don't have any symptoms. So there's no anemia, no constitutional symptoms. If we look at it, Waldenström's doesn't tend to produce bony lesions. It doesn't have renal impairment, and that's because the protein's so large. So the protein's not affecting the renal part, but they do get splenomegaly, hepatomegaly. They also get lymphadenopathy. So the symptoms are just a little bit different for, IgM, MGUS as opposed to other ones. So that's why we will actually type it with immunofixation. Then there's the other ones. And this tends to be a little bit less risk. I've heard, I talk to hematologists and they say effectively anything with regards to if it's non-IgM or if it's non-IgA, if it's non-IgG, then that's the lowest risk one. They'll just monitor it a little bit more, so if it's IgA and IgM. But again, there is no consistent advice on this. So, but if it's non-IgM, these have 0.5% chance of progressing per year. So it's still pretty close, pretty low, but what we end up doing is, again, if it's non-IgM, these patients will be IgA or IgG, and they have risk of multiple myeloma, plasmacytoma, and amyloidosis. But again, if it's MGUS, they don't have symptoms yet at the time. And then there's light chain, which I won't go into, but again, that progression is even less, 0.3% per year. So this is where they won't have any heavy chain. It will literally be free light chains that you identify kappa and lambda on, and that's where you also do urinary protein. So I think I've thrown a whole bunch of stuff at you, but we put it into high risk and low risk, but effectively what you do is high risk is people who are progressing. So within the first year will be the people who progress the most will be the highest risk. So if you incidentally find a protein and you monitor that for a year and it doesn't go anywhere, chances are they've had it for a while and the disease is not progressing and it's pretty stable, and you can move to monitoring that for a year unless they develop symptoms. And so that's the main thing. If someone's actually, progressing from a band of 1 gram per litre, then goes 5 gram per litre and 10 grams per litre, that disease is clearly moving on and it's appropriate to refer that patient. If it's stayed at 1 gram and it was 1 gram last year and it was 1 gram the before, that disease is not going anywhere. It's not causing any problems. If it causes symptoms, then that's reasonable. The gram might not change much, but if they've got unexplained symptoms that puts you down that path, then it's reasonable to refer for further investigation should they need it. These are just some examples. Again, there is no consistency about, someone's low risk, high risk, medium risk. I'm not going to go into that. They do exist if you want to be very particular, because there's the UK myeloma group, there's an international expert consensus. As a general rule, 3 to 6 months, you can just monitor their tests. If they're not progressing, then it's pretty stable and it should be fine. Already gone through that. What they have recommended is people over the age of 80 don't need follow-up. They've gone, once it's low risk for a pretty long time, but progression, just investigate if there's any unexplained symptoms that goes down that CRAB, an acronym. Okay. These are the tests we do. It's a full blood count, urea electrolytes. So again, that's the calcium. Calcium in South Australia is added into the UECs and chemistry. Serum electrophoresis, and immunofixation, free light chains, and the 24-hour. So 24-hour tends to be, so that's where the Benz-Jones proteins, the Benz-Jones proteins is what we find the free light chains that are filtered out through. That's the Benz-Jones protein in the protein, so in the urine. So when it's in the serum, you can test the serum or you can test the protein. The serum will show it up a little bit earlier, but the urine can be, well, you're actually getting free light chains. So free light chains are filtered by the glomerulus and they're reabsorbed by the proximal tubule, which explains why they actually get renal impairment, because it can be toxic to the renal tubule. So that's why they'll get impairment of their renal impairment. So, rule of thumb, if you come across it for the first time, we will do serum electrophoresis, we'll do immunofixation, it will put it into the category, keep an eye on it for 3 to 6 months, and for the first year, and then after that, it's just each year, keep an eye on it, unless symptoms, unexplained symptoms arrive. And then that's it. I hope that was relatively straightforward. We're always there to be contacted or give us a call if you have anything. This is the fun stuff that Steve and I are doing. I like to torture him with big words, and he likes to torture me with odd questions, but it's enjoyable. We're actually just pulling out the history of medicine and pathology and actually looking at it, and then finding out currently half of these actually have, as I say, we had Ferg for mesothelioma, we got Craig for melanoma, and it's, so there are CPD points attached, and some of them are flights of fancy, like the Alexander the Great autopsy that we did. So, if anyone has any topics, we're happy to field them. Smallpox was a friend from basketball, actually, so wanted to know. So if you have any questions, please, happy to ask, but otherwise, give us a call.